Welcome to our TMIT National Research Testbed webinar for August. It's part of our High Performance webinar series, and it's such a delight to have Dr. Jeanne Huddleston back to speak with us on part 2 of Learning from Mortality Review and the Living. And what I'd like to do is just welcome you. I'm Charles Denham, Chairman of TMIT, and I'll be making the introductions and a short review of the news and the polling from last month in July, but a couple of housekeeping details. I'm on slide 3 for those that are reviewing the slides. And just want to make sure you turn your volume on your computer as high as it can be so that you get very good audio. Now, if that doesn't work on slide 4, and those that don't have slide 4, if you just go down to the lower left-hand corner of your WebEx screen, you'll see an icon for request phone dial-in, and you first click on participants. Then you'll see the the telephone icon. Click on that, and then that will help you. I'm on slide 5 now, and those of you that don't have the slides, if you go to www.safetyleaders.org, all one word, and click on that, on the landing page, up in the upper right-hand quadrant of the landing page, you'll see what's new and upcoming events. If you click on the webinar link, the blue underlined link, Learn from Mortality Review and the Living, that'll take you to where you can download the slides, and also it will take you to where the audio and the video of the webinar will be available within about 3 business days, as well as other resources. And one of the resources is a brochure for those that want to join the collaborative that Dr. Huddleston will be addressing today. And I'm on slide 6 showing those of you where that is. Just on slide 7, I want to remind you about the various addresses, social media addresses that we have. On slide 8, our purpose is we will measure our success by how we protect and enrich the lives of families, patients, and caregivers, to those who we serve, but also those who serve. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. I can't think of a better topic than the one that Dr. Huddleston will address. Our disclosure statement is up on slide 9. No product or service for which anyone receives remuneration are going to be addressed at all. And then on slide 10, we have Dr. Huddleston, Dan Ford, who will be introducing us and giving us a great voice of the patient, a message from the patients, and Jennifer Dingman, if she's able to join us as a reactor panel. I turn to Dan Ford, who has been a long-standing patient safety advocate, and working back from the most recent, watch for Dan's article in the journal, in the Joint Commission Journal, inviting patients and families into the root cause analysis, which is an exciting thing for which he has been a tireless champion. He's a retired vice president of a healthcare executive search firm. He has served in multiple capacities on various patient advisory boards to hospitals, currently serves on one, and has also been a co-author of articles in the Journal of Patient Safety, and has been a co-author of the patient-centered section in Chapter 9 of the NQF Safe Practices for Better Healthcare, and the subset components about how to engage patients and families in those safe practices. And he continues to serve in multiple capacities, is one of the team that advises us every other week on Saturday mornings, and has championed the cause for the hospital-acquired conditions and various other things. So, and you can see his bio will be on our website. But Dan, the most important charge we have is really the voice of the patient who you represent today, both as the person introducing us and also as reacting to Dr. Huddleston's presentation and then closing us today. So Dan, would you kick us off?
I would do that, and I'm honored to be here again, and you're very kind with your comment. I know you're going to do a more fine-tuned presentation of Dr. Huddleston, but I just wanted to make some comments. Yes, I was able to watch and listen to the video last month when she gave the first part of this presentation, but I watched the video yesterday, and my advice to the audience today is to buckle up and listen fast. and to be ready for lots of very good information, ideas, and encouragement and support. She's awesome. And I turn it back over to you, Chuck.
Thanks so much, Dan. We look forward to your comments as our reactor. We typically have 2 speakers and multiple reactors. However, Dr. Huddleston's presentation, which we'll show you shortly, the evaluations, she was honored with not only an enormous attendance. I think it's a record for us. This will be our 93rd or 94th webinar. In March will be our 100th sequential monthly webinar of continuing education. And in all that time, I don't think we had a net promoter score of 97, and we never had an evaluation below 8 for her. And since she covered the topic so beautifully, and it's such a critical topic, we invited her back to take a deeper dive, and you'll see from our polling results how that played out. So we won't have 2 speakers, and we'll have Dan and I reacting, but what we want to remind all of you is to hit the question bar and give us questions that I will then pop over to Dr. Huddleston. So my charge is really to hit just some of the things that have popped up on the grid over the summer month of July and August, and especially August, and just want to draw your attention to the JAMA article. So I'm going to just do a whirlwind, just highlights of some articles that might be of interest to you. An article on disclosure of medical error. Wendy Levinson has been a long-standing champion of that. A JAMA article of August 16th, and again, I think this was one of the N2S safe practices, and also just a critical issue to build trust. Second article in the Journal of General Internal Medicine, one regarding vital signs. And I think this is an article that all of us really need to take a look at. We've recently had Dr. Christopher Peabody, an emergency medicine doctor, and critical care doctors like the likes of Dr. Greg Boats, who are just, these are world-class physicians who are constantly drawing our attention to some of the just blocking and tackling that are so critical. And I know, Jeanne, as a hospitalist, that you probably have recognized many of these as you look at the work that you've done. But this study of over 30,000 patients in 6 Dallas-Fort Worth hospitals revealed 1 in 5 of the hospital patients are discharged with 1 or more vital sign instabilities. And so, and we see this pop up. We've seen this pop up over and over and over again over the years. So take a chance, take the opportunity to take a look at that article. The third article I want to draw your attention to is one in Modern Healthcare addressing the CANDOR program, and this was backed by the Agency for Healthcare Research and Quality, and Dr. Mayer, David Mayer, a long-standing champion for patient safety, and I think Dan, someone who you've spent time with at Telluride meetings, who's just been a great champion for quality, states if we can't be open and honest about it at these events, we're never going to learn from them and be able to fix processes and systems. There are some jewels, some gems in this article, and other articles referenced in it. And so I'd like to draw your attention to this as this pilot program and the CANDOR toolkit. And CANDOR stands for Communication and Optimal Resolution. And we know that the great work at the University of Michigan by Rick Boothman is reflectant of the enormous financial impact of doing the right thing. The next article is a Harvard Business Review article, and as you all know, Harvard Business Review is a terrific journal, and we're starting to see more and more healthcare pertinent topics. And we'd like you to just take a look at this one, the new wave of hospital innovation. We all believe we have to keep revitalizing patient safety every day, and so we recommend that you take a look at this article. The graphic there from the article is below. Technical advancements were the first standardizing procedures, now high reliability organizing. And I think Dr. Huddleston's background in getting an engineering degree and coming back to really looking at the analytics and measurement, I think she may have a few comments to add to that. The next article is in the Joint Commission Journal, Minding the Gaps, Assessing Communication Outcomes of Electronic Pre-Consultation Exchange. A lot of folks have kind of poo-pooed or just haven't been able to get going on using the internet and digital technologies, electronic technologies, to help get more information to the right people to make the right decisions. Dr. Huddleston, I've been on faculty at Mayo, and Dr. Huddleston is there. And those of us that are sending people that have complex illnesses who are friends of ours and family members to great centers rely on this all the time. And so unless we really pay attention to certain aspects of this, we can have a problem in patient safety. So we recommend that you take a look at that from the innovation standpoint. And then finally, we continue to have articles popping up that were stimulated by Marty Macary's article about the third leading cause of death being patient safety issues. And one of our favorite friends and just somebody in a whole league by himself is Dr. Berwick, Don Berwick, and his comment is regarding patient safety, this is going to have to become and remain a strategic imperative over time, endlessly forever, and it's not something you could take your eye off of. And so that we recommend that stay in the dialogue, review these articles, pro and con, on how they've been covered. And the reminder, is of the BMJ article by Marty Macary and Michael Daniel. This is the graphic on slide 20 to remind you, if you haven't read it, go ahead and read it. And then a quick literature search, you'll find the debate over the numbers. And we covered a breakdown of them, but we asked you in our polling in July, would you like a consolidated review of patient safety harms of inpatient and outpatient studies in order to understand leading causes of death numbers? Would you like somebody to exhaustively really examine the articles we keep quoting over and over and over again? The CDC, 99,000 deaths due to a hospital or healthcare-acquired infections, revised to 75,000, the IOM report, the OIG report, etc. And we put those up. And 96% of you agreed, 62% gave it a 10. So we are going to engage in dialogue with Marty and others to really help us be able to synchronize the numbers so that those that are new to patient safety and think that they're being exaggerated, that we could really kind of understand them. Now, finally, the polling from last month, and I highly recommend you listen to Dr. Huddleston's part one of this two-part series. We polled you after she gave the presentation of the basics of this topic, and this was our Net Promoter Score, 97%. Amazon has a 69 Net Promoter Score. Google has dropped even lower, where we benchmark ourselves to the highest in the country. USA Banking was the highest. We got a 97 Net Promoter Score, which says when you subtract the 9s and 10s on the evaluation of the question, would you recommend this webinar to a close colleague or friend or this program? 9s and 10s only get a 1. Passives get a 0. Detractors get a -1. You all gave her, those that attended, gave her a 97% and nothing lower than an 8. So we really have tapped something, Jeanne. I think the great interest by the great leaders in our systems. So we asked the question, I am interested in deep dive webinars on mortality reviews and safety learning systems. And Jeanne, 98% agreed, and we got a 68% of our entire audience who responded, which were over half of everybody that attended, and we had 602 pre-registrants. 68% gave that a 10. So that says you want us to do deeper dive, which we will. 87% strongly or very strongly agreed. Now, I'm not going to read through this because I want to have all of the time to Dr. Huddleston, but I'll allow you to skim through what you put in our free text entry. And Kyle Kemp, who does a fabulous job running these webinars for us, said, Dr. Denham, please remind them to fill the survey out at the end of the presentation. Please do it, because that guides us on what you want to hear in the next webinar. And so as you look over these topics, and we can come back to them, Jeanne, after you give your presentation, but we've got a number of cardiac issues, communication, ED mortalities, failure to rescue. Rescue is a big deal. And a lot of these topics, which I won't review now, but they're in the slide deck, and then, Jeanne, we can come back to them. A second slide. So our audience, look at sepsis, how frequently sepsis was addressed. Misdiagnosis. Medication errors constantly is a big issue. Again, not my job to review these for you today, but I wanted to give you a feel for the kinds of answers you may give us when we ask you the topics that you'd like to hear and address. So as you skim over them, you see a lot of the common ones, but we also see some identifying coding inaccuracies. That's interesting. We haven't seen that before. We asked the question, would your hospital be interested in participating in a 100-case safety learning system collaborative? So we asked the question, and those of you that are jumping in on part 2, you'll have to watch part 1, but I think Jeanne will be covering the material and offering to you. She's got more than 40 hospitals involved in a 100-case safety learning system collaborative. So review, and I'll have her describe those. But we ask you, would your hospital be interested in doing that? Again, now we got a spread, more kind of not a bell curve, but we got a spread, and we had 17% of you that were watched gave it a 10, and you could see 17, 12, 17 were agree, 53% you would call it agreement, and but then we had a good spread, and we had a certain number that would say no. I vigorously, I would not. So let me move on to a couple of topics that we also are covering, but that gives you a good feel for what the response to Jeanne's presentation and the topical review and your interest area. So we're also tackling in a broader context all cause, threat, and harm to those who serve and those we serve. Those who serve are our staff, our caregivers, and our non-clinical staff, everybody who's involved in our organizations, and those we serve, which this is always where we focus and why we ask Dan to give, to open and to close our session. We ask a free text entry question. What are the all-cause threats and harms that you would like us to cover in future webinars? And we had active shooter and a number of those. We've covered those. We have cybercrime, constantly see communication, drug events, failure to rescue. We see failure to respond and staffing ratios, and again, MedRec. And so we see a lot of the areas that we all need to just keep focusing on, but also hostile work environment and some of the others. And so, again, these are in your deck. I'm not going to go over them. I just want to give you feedback as to what your colleagues are saying in an all-cause threat and harm context. These are the areas that you all gave us. We asked free text entry, and that's why we ask you in the polling to do the same thing. So, and then finally, we've covered, we started to uncover that there are an enormous number of harmful events that are preventable. These aren't harm we do to patients, but harmful events for which prevention can have enormous impact. The things that are highly frequent, highly severe, preventable, and measurable in children, K through 12, college, and through the workforce, up to 65. And it turns out that these topics, which we are developing a program for called the Medical Tactical Program, or MedTac program, cardiac arrest, choking and drowning, opioid overdose, anaphylaxis, active shooter, the transportation and non-transportation events that can occur at an institution like a school or a hospital, and bullying and workforce violence. We've complemented it with the National Safety Council injury facts, and just for your slide deck, not to go over today, but you can see the leading causes of fatal unintentional injuries and a number of the areas that we're focused on with MedTac, for which most organizations haven't put the preventative programs in place. These are unintentional injuries, then the non-fatal unintentional injuries. And then in the last webinar, we gave you the top 10 leading causes of death by CDC. Again, I'm not going to go through them because we're sparing our time for Dr. Huddleston. 10 leading causes of injury deaths. And as we start to look at these causes of death, you see the same pattern over and over again of the preventability if we can equip clinical and non-clinical staff with the skills, CPR, use of the automatic electric defibrillator, understanding where to meet first responders, and these terrible events of the active shooter events, which, and we're not going to show any more data on that in a broad audience because the recent article has shown when you publicize them, the copycat events likely could be prevented by a third, which is a pretty amazing study. And we'll be having a collaborative on that, but we'll keep it very tight. We ask you, do you want a deep dive webinars on these MedTech events? And you can see not as high as what we got with Dr. Huddleston, but we still see a strong response for which we'll address them. We ask you about the active shooter readiness, that ask you whether do you need briefings on best practices for active shooter events. About 29% of you gave it a 10, 14% gave it a 9, and then broke down from there. So this is strong enough for us to believe that we need to continue to address these in future webinars. And then finally, we put together, once we understood these events, especially when you get in a group setting and that, for instance, children with sudden cardiac arrest, a quarter of them happen at athletic events in apparently healthy kids, and that the survival rate drops 10% for every minute that you don't perfuse them. We've put together, this is an R&D project using some, and we thought we just give you a view of it, and we'll ask you a polling question about it. But this is something we're piloting with organizations to look at the critical actions in response to emergencies. At an event, if you get the 4 or 5 people together at the beginning of an event, who will call 911 if we have a sudden cardiac arrest or someone's injured? Who knows where the first aid kit is? Who knows where the EpiPens are, or we'll be able to pull the audience if we need an EpiPen, a Narcan kit, or a Stop the Bleed kit. And so you'll see more work on this that came from the MedTech work in the weeks and months ahead. And Dr. Greg Boats really, it was his idea, and we're building it with him. And then finally, this week came over our transom, the fact that most hospitals are not using the same emergency codes, even within healthcare systems. This is an example of one that was harmonized, and we'll be undertaking a program to help hospitals harmonize their codes, because now active shooter has to be part of them, and really address some of the critical issues. Turns out that there have been deaths in hospitals because people don't know what code to call, and we'll get into that in more detail. So I rushed through that overview quickly so that you could see what your polling was. I'd like to move to Dr. Huddleston. For those of you that haven't heard her speak, she's absolutely terrific. She's the past president of the Society of Hospital Medicine, a hospitalist, founder of the hospital medicine, medicine program as the hospital. She's a hospitalist at the Mayo Clinic, chairperson of Mayo Clinic's Mortality Review Committee, and embarked on this project to undertake a study of every death at the Mayo Clinic. She completed a residency in internal medicine and advanced general medicine at the Mayo Clinic, and then she went back to get a master's degrees in clinical research and industrial engineering to really be able to help us understand the measures and apply the analytics back to this critical area, and then has championed that cause at Mayo Clinic, and now, as we said, has more than 40 hospitals involved in collaboratives. And so with that introduction, Jeanne, take it away. She'll be our main speaker, and we'll listen to everything she has to say. Dan and I'll react, but we like to have you put your questions in the question box, and then we will feed her those questions so we make sure to get them answered. Jeanne, take it away. Thanks.
Thank you very much, Dr. Denham. I am honored to be with you again this month. I have included in my presentation a little bit of last month's presentation for those who weren't able to join us then, and have proceeded to get into a deeper dive in terms of how we actually do the reviews. So this is part 2, a deeper dive. I'm going to go through our experience, some of the background that I shared last month, and then I'm going to go through a step-by-step approach to how we actually go through our beginning-to-end process from a mortality perspective, and how we're actually translating this now into other very challenging cohorts that we still haven't been able to wrap our arms around, like readmissions and high-cost cases, et cetera. I'm going to go through just a couple of case studies, and when I get there, by using your question and texting area on the right, I'm going to actually try to engage you in some conversation in terms of, as we read these cases, what you think the opportunities for improvement in them might be based on the categories that we use to categorize our our issues that we identify. And then I'll speak briefly about the Safety and Learning System Collaborative as an invitation, hoping that as many of you as are interested will join us. So this is the hospital where I spend my professional life and where the stories that I'm speaking of will be coming from here. I mentioned last month that the reason that we embarked on this entire journey was to learn. We realized that we were getting only the tip of the iceberg with the global trigger tool, our voluntary reporting, and the information we got turned into a counting exercise where our executives and our leaders would see run charts every quarter. And if there was a blip in the chart or a trend going up, they would invariably ask us to go look at something, but by the time that happened, it was probably 3 or 6 months after the data was actually those patients were actually in the hospital. And so we weren't getting anywhere, and we weren't seeing much traction. And with the global trigger tool, frankly, we didn't make a single change. And that was very, very frustrating to me and my other colleagues, and there were a whole host of us working on this in the clinic supporting our time, and it didn't seem to be very fruitful. We really wanted to learn more about what we couldn't see, what was going on. And at the time, a colleague and I, Dr. Dennis Manning and myself, were working very closely with the IHI, and that's when the 4 boxes came out and the Move the Dot initiative, and we thought to ourselves, okay, according to the IOM report, adverse events kill people. So if adverse events kill people, maybe we need to look at the deaths. Maybe if we really dove into the deaths, we would understand more about the things that are happening within our hospital and the things that we could fix. We wanted to get to fixing things. So we did a 100-case review. We just took 100 consecutive cases. We started that particular day we had the idea, did 100 consecutive, and we have roughly 100 deaths per month, so that was about a month's worth of deaths for us, and learned a tremendous, tremendous amount of information. There were lots of adverse events that we identified, but there were 5 that had some serious, serious harm, and 2 that we believed that we had caused their lives to end earlier than anticipated. And when we reconciled everything we found in that 100-case review, none of it was reported anywhere in our voluntary reporting system. And that led us to believe that maybe we were onto something. And that initiative took place in 2003. I presented that to our hospital board. Within a month, I was in front of our board of trustees, our public leaders, and I'll never be back there in my career. I'm sure it was a one-stop shop for me. But from that moment, when our public leaders heard what we identified in those 100 cases, we have been doing mortality review ever since. We've reviewed more than 100,000 deaths, and we identify 5 to 6 times more patients harmed by our system in our mortality review system than we do all of our other initiatives combined. And so we believe that we're actually getting to the part of the iceberg that we wanted to start learning from. And now we know that if this happens in patients who die, what about those who survive in spite of us? So we're getting to the readmissions and the high-cost cases to figure out if we can understand in even greater depth what's going on within our institution. This was the original charge, and I just want to point out number 1, because number 2, 3, and 4 are pretty standard language for safety initiatives. It is all about the learning. We wanted to create a meaningful mechanism. So this was our charge in 2004 when we didn't know what we were doing or how to get it done. We had to create a meaningful mechanism to review cases. If we could not find a meaningful mechanism to learn, then we would have scrapped it and started something else. So it took us a solid 5 to 7 years to actually get in a rhythm that we've replicated month after month after month since then. But we defined meaningful as something that we could understand, measure, and improve. And if we couldn't do that, we needed to find another thing to do. One of the things that's been very interesting to me, another patient safety advocate, Dr. James, who wrote this article, validating the issues around the global trigger tool that we were facing, and that it has certain limitations, but estimating the large number of patients that are harmed, and if you look at those who die versus don't die, he believes that 10 to 20-fold have serious events but don't die, which is, again, why we're moving into what our Chief Quality Officer calls learning from the living in addition to mortality review. So the guiding principles. of the system that we developed over the last 13 years. It's system review, not peer review, and this is the hardest part for docs, specifically docs. Nurses get this a lot faster. For the docs to get their heads around, is that this is not peer review. I sat in a hospital last week, one of our collaborative site hospitals, and their pathologist came, and he and I bantered for a solid 15 minutes about a particular patient who had a bad outcome, but the doctor didn't do anything wrong. And he was right. The doctor didn't do anything wrong, but I kept asking him the same question. Is this the system that you would have want your loved one cared for? Is this how you wanted their care to go? And he kept saying no, but the doctor didn't do anything wrong. I said, I understand the doctor didn't do anything wrong. Improvement. Is there an opportunity for the system and the processes to support that doctor and to support those nurses so that these bad outcomes don't happen? And ultimately, we came to a common understanding about system reviews and not peer review. But that's a really important conversation that happens over and over and over again when we're beginning our process at other hospitals. And believe me, one we had great debate over when we were first starting. My thesis work in engineering was around reliability science. And so from a high reliability organizational perspective, this is deference to expertise. Now, when we started this process, I wasn't an engineer yet. It just made sense to me to ask the people who actually did the work to review the work. Just common sense to me. But in the concept of reliability organizations, deference to expertise means the exact same thing. Ask the people who actually do the work whether or not the work was okay. And so in our translation, every case is reviewed by a practicing nurse and a practicing physician. We don't know what we don't know. And most of what we find that we can do better are omissions, things that we don't do. So it's really hard to see what's missing if you don't know something's supposed to be there. Example, recently, one of our cases, there was a patient whose blood in the emergency department order was put in, and it took 45 minutes for the blood to be drawn. Well, I'm a hospitalist, so up on the floor, 45 minutes is really good. I mean, I would be impressed with a 45-minute time to draw. But theirs is supposed to be 10 to 15. And so they identified that opportunity for improvement and went to work deeper to figure out what their draw times actually were and what the improvements could be made. If you had a non-practicing nurse or a non-practicing physician in the emergency department review that case, they would have missed that one. And so it's those sorts of examples about why we use practicing nurses and physicians. We include all of the information centrally into a central registry, and our registry, our mortality review system, was designed to be an enterprise solution. And so all of the information from all 20-some-odd hospitals that we have in 6 different states rolls into one system and aggregates at an enterprise level so that we can compare hospitals, compare floors, compare types of floors, compare service lines, so we can slice and dice the data any way that we need to. Our next generation safety learning system that we're in the process of still building right now replicates that particular component of being able to record all of the information at an enterprise or system level for system learning. I think our magic has come, in addition to the practicing nurses and physicians, our magic comes from the multidisciplinary, multispecialty sessions, where we have nurses and doctors from around our institution of all stripes, of all breeds, of all specialties, etc., sitting in the same room talking about the same case. It is the best clinical learning I've ever had, because when else do I sit in a room with an orthopedic surgeon, neurosurgeon, critical care doctors, trauma surgeons, GI, ID, cardiology, pulmonary, nurses from around the institution, our transport teams, so our ambulance or flight teams, pharmacist, coroner. When else do I get to have that type of clinical interaction when we're all talking about one case and sharing what we know? You learn a tremendous amount about how your hospital works, how your healthcare system and your community works, and then clinically as well. That has been the root and the groundwork for all of our culture change, because those individuals in that area, when we're having those conversations, we learn how to talk to each other about really hard stuff. And it's been fascinating for me to watch over the last decade that some of the people who originally started in that space with us and those people that have been coming to those sessions, those individuals, as they mature through their career, have moved into leadership positions because they've had this sort of laboratory of growth of communication around difficult conversations. And so it's been really interesting to sort of watch a very unintended thing, good thing, come out of this. That's been beautiful to see happen. And then the last thing is the implementation is local. What works at Mayo does not work anywhere else. Everything has to be modified for local operations, and we did that even as we grew it within Mayo Clinic proper, is that places had to be able to learn and do the reviews in a way that made sense to them. The only things that they had to abide by were the top four. It's system review, practicing nurses and doctors, record the data centrally, and talk about it together. Those were the four guiding principles. How they got the work done has locally been up to each individual hospital. I mentioned the omissions and commissions. So these items along the bottom of this Pareto diagram show the major buckets of things that we've been working on: delayed or misdiagnosis, failure to rescue, procedural complications, triage errors, infections acquired in the hospital. And the biggest ones for us are the delayed and missed diagnoses and the failure to rescue, which is a delayed recognition and rescue of deteriorating patients. That teal-shaped or colored bar there are our patients who met our RRT criteria and we didn't rescue them. That's how we define failure to rescue. And so you can see that the entire 40% or maybe 35 to 38% of the issues that we have amongst our three biggest hospitals, this is an aggregate of Arizona, Florida, and Rochester, are all omissions, are all things that we delayed doing or missed doing. The common things that you would refer to traditionally in patient safety as adverse events, those are the procedural complications and then infections. And then you can see medication is even further down. Triage errors we're looking at as omissions. We put the patients in the wrong hospital. Documentation and communication opportunities, things that were missed. The vast majority of what's showing up here are things that we don't do. And that makes sense because adverse events are rare. And so if we put in a huge amount of effort to fix a particular adverse event that was a commission, we might, but because it's rare, we might put a bunch of time into fixing it and it won't happen for another 5 years. But is it because we did such a good job of fixing it? Or is it because it's just random variation and it was time again? But I can tell you, by you looking at this Pareto diagram, the omissions are happening frequently. And if you put something into place, you will be able to see within 6 months to 12 months, you'll be able to count the lives your hospital is saving. The Wall Street Journal had their article on misdiagnoses, which gets to our whole missed and delayed diagnoses, and considering that some of them are preventable. So what I'm seeing is a shift away from traditional concepts of commission-based adverse events, moving into the omissions as well, and what we're now calling within our institution opportunities for improvement. Whether it's an omission or commission, the question is, can we be better? And I believe that we can be better at things like pneumonia, heart failure, kidney failure. Those aren't very sexy, right? But lots of patients have them. And if we can get those better, if we can do those better, diagnose them sooner, treat them sooner, time is tissue concepts, then we will save lives. And it's because we need to look at it from a system failure perspective. My example I gave last time, and I'll share it again, was about mesenteric ischemia. Mesenteric ischemia is really hard to diagnose clinically. It can be mixed up in a very large differential with a whole very complicated picture. So when we had 5 in 1 quarter, that caught, for some reason 5 seems to be the trigger number that makes us start thinking we've got a trend. But when we looked at them, there was one in GI, emergency department, peds, GI, and general medicine. None of those people worked together. You saw how big the hospital was. None of those people know each other. So for any one of them, it was a one-off. And in any peer review setting, each one of those 5 doctors would get a very nice little note from peer review telling them, yeah, we know that mesenteric ischemia is difficult to diagnose, but basically try harder next time. That doesn't help anybody, certainly not the doctor or the patient. But when we looked at these from a system perspective, and we had 5 in 1 hospital. We looked in Arizona and Florida, one of them had it, the other one didn't. So you could say that one that didn't didn't review their cases very well, but actually they're the site that reviews their cases with more energy and tenacity than any of the rest of us. So the fact that they didn't have any actually meant something to us. And so we put, as a result of a recommendation that came out of mortality review, we recommended to the practice leaders that they put a group together to look at this. So the practice followed through, they did that, and we identified that one of the site that didn't have any, had a different abdominal imaging protocol when mesenteric ischemia was in the differential. We have now spread that, and I haven't seen a delayed diagnosis of mesenteric ischemia in our facilities in years that's died. Now, I don't know about those who haven't died, but that has actually died. And so when that was a system thing, we could actually create a system to support the providers on something that's really hard clinically and individually to diagnose. So that's what I mean by a system problem. And we'll get to some more of it in a bit. This is where we're going to get into the step-by-step approach, and I'm going to go through this diagram on the future slides. It is a combination of individual reviewer work and committee consensus-based work. There's raw information that's put into the system, that those cases are assigned to reviewers. If either or both of them find anything that seems out of normal or doesn't follow a typical practice pattern, they identify them as opportunities or issues. If they identify it, then that case comes forward for further evaluation by a committee lead who prepares that case for a case discussion, and then that's where the committee portion takes over, and they discuss the case, come to consensus, and if they believe there were opportunities for improvement and there are opportunities to mitigate future events, that data is aggregated for future learning and reports are generated. We share our data with the quality committees and the clinical practice committees. So step one in the new system is case entry and assignment. So case entry, hospitals each have a different way of identifying who died or who the readmissions are or who the highest cost cases are. So identifying that list of patients that's going to be reviewed and then entering them into the system either manually or with an electronic transfer of data. Our basic case entry includes demographics, admission details, discharge details, and a clinical summary. In some cases, people put in a timeline, my research nurse did this for about 8 years, would do a very basic patient flow summary. As an example, 82-year-old female came into the hospital through the emergency department with shortness of breath. She was found to meet RRT criteria and was transferred to the ICU. In the ICU, she was intubated, ventilated for a number of days, and developed ARDS and renal failure. The family conference was held. They decided for comfort care measures only and to withdraw life support. Patient died in comfort on X date at X time. So just a very brief summary of what the patient's journey was at a high level. We actually found that those were our favorite summaries. However, the time it took the research nurse to do it was phenomenal. And so we've moved to doing copying and paste of the clinical summary portion of our discharge summary. Not as helpful. We could get into a whole conversation about copy and paste of notes in the medical record, but that's sort of out of scope right now. But it was much more time efficient. So we went that particular route just to have some clinical information for the individuals. The admission and discharge details are important because it gets down to when you're actually going to be assigning an opportunity for improvement or an issue to an area. It has to have some attribution so that you can do some data analysis, at some point in time. So our admission details include where was the patient admitted to, what was their code status when they came in, and what service line was taking care of them, not who was taking care of them. Because remember, this is system, not peer review. In the more than 10,000 consecutive charts that you could go through of our reviews, you will not see a single nurse or physician name in any of our reviews, because it doesn't matter who the person is. If something happens when I'm on my 6 of 7 nights in a row, that same thing could happen to the next person who's on their 6 of 7 nights in a row at 2 o'clock in the morning. So we recognize that we're influenced by the system and the care and the things that are going on around us, and so we remove the individual's names and look at the system. So we look at those specifics on the admission and the discharge segments, and one of the first things the reviewers do is look to see if there's changes. Is there a change between the admission location and the discharge location, the admission code status and the discharge code status, the admission diagnosis and the discharge diagnosis? If there's changes in there, that tells me that some potentially unexpected things happen, and I need to look into those areas and understand why those changes occurred. It's part of being a detective as you're doing these cases and actually, frankly, asking the 5 whys. Why did the patient start on the general care floor and die in the ICU? Why did the patient come in with pneumonia and leave with a colostomy? Just why questions that lead you into doing your reviews. In our current collaborative that's going on, the site's picked from 3 different scenarios to do the case reviews. And some are, I'll just go through them and show you which one Mayo's using and which one some of the other sites are using. So option with screening cases to be reviewed by a physician. So in this particular case, I should say screened cases to be reviewed by a physician. So they do the case entry and then a tier 1 screen. So a tier 1 screen, so if particular parameters, I don't know, the patient has a hospital-acquired pneumonia or a medication event or something that leads them to say, yes, this needs to be reviewed by a clinician. So the physicians don't review all the cases. They only review those ones that are sent to them after a screen. Another approach that's being used is same concept, only having a nurse and a physician review the cases that pass that screen. Again, they're not reviewing all of them, only the ones that are passed off to them. And the final, this is the approach that Mayo Clinic has used. The cases are entered and automatically a nurse and a physician review the cases. We have our practicing physicians who do these cases are typically mid-career attendings. We personally do not involve residents in the reviews. Our perception is, at least in our culture, the change management and the involvement is easier to obtain, especially when the voice of what we find as opportunities for improvement leave the room if the reviews were completed by people who are at least mid-career. We need thought leaders, we need respected clinicians, because when we walk out of that room and have for an area a couple of opportunities for improvement, they know that these weren't reviewed by trainees, that this opinion is actually coming from their own peers. And that's a different conversation that we have when we leave the room than if we said, hey, you know, a couple of first and second year residents reviewed the cases and this is what they found. That wouldn't fly nearly as well as we had a room of mid to senior level clinicians, including surgeons, intensivists, and generalists, and this is what we found. That's a different conversation. Same from a nursing perspective. We don't have nursing students review these cases. We have practicing nurses review these cases, and the vast majority of them are at least mid-career. One of the questions that I saw was, how do we get our physicians engaged? We started with the passionate. There were 3 or 4 of us. We started with centralized reviews. We did as many as we could. We had a nurse administrator working with us, and we did as many as we could. Once we had the traction and had our system down, then we started localized reviews by inviting critical care to join us. And when we invited a particular area to join us, we asked their clinical leader to appoint somebody. So it had to be leadership endorsed work. Now, we already had institutional support for this work from the highest levels. So that was what the conversation we could have with their clinical department chair. And then we went to the clinical department chair asking for who can do this work, who's a good system thinker, and then they were assigned to us. And so we grew that slowly, going group to group. And now keep in mind, we did this over a 10-year period of time. This isn't something that just magically happened. I always recommend, which is why the collaborative, start with 100 cases with people who are passionate about this type of work and just see what you learn. And then from there, figure out how you can operationalize a system. But our providers are now appointed by their clinical leaders, and then we also have providers who just volunteer because they really enjoy this work. So the second step, once we have our passionate group of people, is for them to actually do the reviews that are assigned to them. And they receive an email that says they have a case to be reviewed in the system, so they don't have to go into yet another application to find things. And the reviewers all have special characteristics. They have to be system thinkers that support transparency. They have to be brutally honest and believe in tough love. And I'm a mom of teenagers, right? So it's a language I'm becoming familiar with. Can we do better? Do we believe that we can be better? And that sort of tough love of saying the hard things about what need to be improved rather than just accepting the status quo is not always easy. And so having someone who's willing to believe in tough love for the organization. And this comes out when you review maybe your boss's case, whether you're a nurse or a physician, and your direct supervisor cared for the patient and you find opportunities for improvement in that care. You still have to be able to write it down. You still have to be able to talk about it. And so that level of courage and honesty is crucial. And so we look for those sorts of people. I'll never forget the case that I reviewed that had one of our board of governors involved in the care. And that one took me a while to do, but we had to do it. Can we review the patient's experience where the system failed rather than just reviewing the peer's care? So again, system review and not peer review. The issue of the mesenteric ischemia being a system issue, not just a peer issue. And then the professionalism is critical. We are expected to maintain the confidence of the staff whose cases we review, and also the confidence of the people in the room when we're having some of these pretty hard discussions together. Their responsibilities, so reviewers' responsibility is timely completion of their chart review, identify places and processes where the systems have failed, participate in the monthly review sessions where we have the case discussions where we come together. So the room, we'll get 30 to 50 people in a room, and we just invite all of the reviewers, and people come if they can. Removing the personal blame and supporting transparency. So the characteristics and their responsibilities. When they're doing the review and looking for opportunities for improvement, I ask them to do a few things. Compare the admission and discharge details. Review the nurse's notes. Those free text notes that the nurses put in there, that's where the gold is. If they take the time, if a nurse takes the time to type out something, it means something. And what you'll learn very quickly is some of your hospital's secret language. So our hospital nursing secret language is SX notified, service notified, 2 words. An hour later, service notified. An hour later, service notified. What does that say? That says they told the service about the vital signs or about the patient's issues and nobody came. Another hospital that I was in, I saw service notified. Another hospital I was in, the code words were no new orders. Vital signs such and such, no new orders. Patient's pain still 7, no new orders. Same message. I've called, nobody's coming to my help. And so those nurses' notes are crucial. That's where you'll find your teamwork things. That's where you'll find your communication things, and that's where you'll find a lot of your delayed cares. So we've got the admission and discharge details. We've got the nursing notes. The next place I go is the vital signs. Did they ever meet RRT criteria? If they did, yes, then I look to see if an RRT was called. If they did not, now I've got a potential failure to rescue, and I dive into that area of the chart. The fourth place I look is I scan their labs. The last place I look are the clinician's notes. And I don't know about your hospitals, but we have so much copy and paste going on with the assessment and the plan that I can't tell one day to the next. The problem statements are not, the problem list isn't reorganized every day, so you don't know what the biggest problem that is that day. It's a copy and paste from when they first came in 10 days ago and things have changed. So I frankly go to the physician's notes last, and I only go there if there's something I'm trying to figure out. So if my admission and discharge details are identical, the length of stay is consistent with a course of care for what the patient had, there are no nursing notes that have any clues or indicators in them, the patient never met RRT criteria, and the labs are all consistent with their disease, I look at those 4 things and I stop. And then I move on to the next case. So it's a very cursory review, but through 10 years of doing it, I found at least in our records where the money has always been. And if you find something that's abnormal, like I mentioned, the patient who came in with pneumonia and left with a colostomy, something happened between A and B. That one's going to take some time diving into, and I'm going to have to get into the physician's notes for that one. So I allow those screening issues to let me figure out where I go into the case. Now, the key portions for all new reviewers to understand is I'm not looking for preventability, I'm not looking for causality, and I'm not looking for attribution. I do not care if what I find is a delay in diagnosis is related to the patient's death or could have stopped the patient's death if we had acted sooner. So for the patient with metastatic cancer who's got a bowel obstruction and they're septic, but they're still full code, and we have RRT criteria for 12 consecutive hours, but no one calls the RRT team, that is still a failure to rescue because it's unacceptable. We either need to get the code status changed or we need to act, because at that moment in time, they're full code, and we are ethically obliged to either do something or make something happen. It even could be the ethical conversation of having, do we really need to do this, Mr. Jones? I believe that this care is futile. I believe these complications could happen. Do you still want to proceed? But we have to have that conversation. If we don't, we write down that there was an opportunity for improvement. The patient met RRT criteria for 12 hours. So it's not about the preventability. It's not about the causality. If it was, we'd never get to the fact that our pain scores at the time of death for patients are unacceptable. Because if I was looking for preventable death, I would never pay attention to their pain score at the time of death. So you really, I'll keep saying it over and over and over again because this part is crucial. People clinically start saying, well, the patient was really sick, or, well, gosh, they were super old and they were going to die anyway, so I'm not going to put this in. If we're going to gather the most comprehensive data and understanding of where our system has an opportunity to improve, then we have to record it. And 2 questions to ask yourself if you're struggling with a particular thing. 1, did it meet the standard of the care for your institution? So a pain score of 9 in a hospital patient at Mayo who dies of cancer, is that the view Mayo Clinic has of itself, is the type of care it delivers? If the answer is no, then you have an opportunity for improvement. And if you're not sure after that one, you can ask yourself, if that was your loved one, your wife, son, daughter, parent, and you love them, would that care have been okay if you were standing in the room and that was your loved one? If the answer to that question is no, then your institution has some opportunities for improvement to care for your own loved ones. And that's what I do over and over and over again, is put the picture of someone in my family in that bed and ask myself, could I stand still and watch this? And if the answer is no, then I'm going to mark it as an opportunity for improvement. Okay, I'm going to get off my high horse now. That's something I believe very strongly in. Once the reviews are finished and the things have been identified in the system, then there's a process of getting ready for the case discussion. And this is typically done by whoever's facilitating. We have 2 physicians who trade on and off doing the facilitation for the cases. We have physicians doing the case discussions or facilitating the case discussions because of our culture. And at other institutions, this may be different. But if we're going to have a room full of surgeons and critical care docs and ER docs and hospitalists and cardiologists, et cetera, we need to have a physician at the front of the room actually facilitating the conversation. But there's a nurse lead who's sitting up front and who participates as well. So that nurse lead and that physician lead actually go through all the cases that have opportunities for improvement as found by the reviewers and reconcile them. So if they have identical things, they can collapse those into one thing, so you're not talking about the same thing twice. If they're different things, then they can stack them up to see how they want to talk about them. And if the reviewer's descriptions aren't clear, then unfortunately these particular leaders have to go back to try to understand it more, or call the reviewer and try to get some more information. The reviewers are coached to put in as much information as necessary to allow someone else to understand their concern without having to read the record. From a reconciliation perspective, and I just saw one of the questions about inter-rater reliability, frankly, I don't care about inter-rater reliability, because I have a doctor and a nurse reviewing the chart. they trained under different rubrics, they work from completely different parts of our EMR, they have completely different job scopes of work. So there is absolutely no way they're going to come up with the exact same thing every time. What's important is that they come up with different stuff. So each of them, from their own perspectives, when they bring in their differing opinions, you have a much fuller understanding of what actually happened to that patient under your care. Now, we have done post UA or QA type work, quality assurance, where we randomly select 10 cases every quarter, have them reviewed by someone who has more than 10 years of review experience, and there's several of us now, and we have a 98% success rate. And what we define as success is when that second reviewer goes back blind, or the QA reviewer goes back blind, do they find the same opportunities for improvement? And 2 out of every 100 cases, the QA reviewer finds something that they didn't find. And we've been happy with that level of quality assurance and reliability, so to speak, of our work. So they prep for the committee. Step 4 is to go into committee and case discussions. This is where the Chatham House rules play in. I didn't understand what we were doing. I came across this years later, but this is what we're doing, and so I've ascribed the definition to it after the fact. But the key part is that we operate under Chatham House rules, so the participants sitting in the room for the case discussion are free to use all information available to them. That might include going into the clinical record and pulling up that patient's information, finding out, gosh, what time was the medication given in reference to when the RRT was called, or when was the resident called, or when was there, or the timing of things is often what we dig into. All information is available to them. The identity of the patient and the providers may not be revealed. And the identity of the persons doing the case, discussing the cases in the committee may not be revealed. Again, that specifically speaks to the culture at Mayo Clinic, and maybe in other places where there's a little bit of a hierarchical nature to things, and where there is still, even after decades of work in the patient safety culture world, we still have a little bit of blame stuff going on. It goes 2 different ways. We don't, so that the second to last bullet, we don't want anybody to feel blamed. We just want to identify opportunities for improvement, and that's why we talk about them as opportunities, not as adverse events, not as safety issues, just plain old opportunities. But we also don't want the people carrying the message to receive any retaliation from peers or leadership. So when we walk out of the room, we don't say, Huddleston said that you guys have this opportunity for improvement because it took you 6 hours to call the RRT. What we say is the Mortality Review Committee discussed this case in detail, and we believe that there was an opportunity to call the RRT team sooner. It's a different conversation and helps everyone feel safer. After the case discussion, we have and we're talking about the case. A key component of that is a consensus-driven classification of opportunities for improvement. So let's go through a couple of cases here. Read through these, and then if some of you are able, would you be willing to type into the text section whether or not you think in this particular case there's a communication, documentation, delayed or misdiagnosis, truth. The things on the box on the right are our major categories that we discuss or we categorize things into when we're finding opportunities for improvement. So if you have a second and can type anything in, that would be great. Otherwise, I'll just go through it verbally as well.
And Jeanne, what we'll suggest people to do is you could type it into the Q&A. Your response won't be a question. It'll just be the response, and feel free to do it. If you don't do it, it's okay too. And then when we get to the Q&A section, we'll still use the same section.
Okay. So they can type in that bottom right-hand box?
Yes, ma'am.
All right.
And they just know they're not asking a question. They could just say choice. Just use the word choice. So
okay.
I see, for instance, what a person just put delayed or misdiagnosis. They're responding to you beautifully. Just do that in the Q&A, and then we'll use the Q&A. We'll use the same section for our Q&A section later. I can see people are starting to respond to you, so thanks.
Awesome. Correct. So in this particular case, there were delayed and misdiagnoses in terms of, there were two of them. There was sepsis, and then there was the procedural complication. There was a delayed rescue. There was no transition to ICU, which is important to note. Procedural complication. Treatment issues, yes. So they continued to treat an episode of PAF out of telemetry. The resuscitation issues in here, this patient met, so failure to rescue or delayed rescue, deteriorating patient, failure to rescue. That patient almost continually met our RRT criteria on post-op day 4 and on day 5. So there was over 24 hours that this patient was deteriorating that our RRT was never involved. Treatment issues, yes. They did not intensively enough resuscitate the patient on post-op day 4 or 5. They missed and delayed the diagnosis of the abdominal problem on post-op day 3. And I agree, choices could be all, except maybe palliation or triage. It depends on whether or not you look at palliation as only an end-of-life issue or whether or not someone should be comfortable even when they're alive. So that's an interesting conversation that we often have. So these, as you've loaded and put these issues in here, these are not traditional things that someone would say through a voluntary reporting line, I have an adverse event. Because every single one of these, almost every single one of these is an omission. Next case. 82-year-old man with COPD, pancreatic cancer, bowel obstruction. He had post-op delirium, respiratory failures, pain meds were held. As some nursing notes, this came out of those nursing free text notes, patient routinely calling out in pain, family members asking for him to be kept comfortable. But he was DNR, DNI at that time and not comfort care only. The team was worried about his respiratory suppression. Average pain score on the 24 hours prior to death was 8 out of 10, and he was made comfort care hours before he died. So I'm seeing here communication, delayed or misdiagnoses, palliation, treatment, palliation, absolutely. So the team initially on the second day after his palliative surgery to relieve the obstruction didn't recognize his post-op delirium for what it was, which was hypoxemia. Instead, they just stopped the pain meds, hoping he would breathe a little bit better, and didn't actually get down to the roots of some of the issues. And so from that moment on, we had lots of treatment opportunities, communication, and delayed or missed, in this case, potentially even wrong diagnoses. There was also, from the palliation perspective, a chance to have a goals of care discussion much sooner. So those are the types of things that we have. So we'll have a case like that, we'll have the discussions, and then we will come to consensus with everybody putting their input in terms of what we saw based on what the reviewers already found, and then we agree, and that's what comes out is the final report, only what comes out. And that last step is the synthesis of all the inputs. So the synthesis of what the reviewers put in terms of their textual writings, and then the conversation. And it's that committee lead's job at that point in time to synthesize and summarize in very succinct form what happened. And here's an example of a final case summary that comes out of our system. This was written by and reviewed by either written by the nurse and reviewed by the doc or the other way around, but two people are always involved. Somebody does the initial draft and somebody else does the cleanup and making sure that everything's correct. Things like 78-year-old male. If you accidentally put 78-year-old female and it goes out, the people receiving it who may not like this process much may have the conversation of, gosh, they can't even get the gender right. How in the world can they review a chart? So the integrity of all of the work and all of the people working with you in this process is summed up in this one note, and we take it incredibly seriously so that the reputation of those that are involved and their integrity and their hard work is honored to the extent that we can by being as accurate as possible, so that there aren't, to minimize the miscommunication that can happen with the written word. And so you can see here that this is very time-based, orderly, factual, only what happened. RRT activated, transfer back to medicine, repeat video swallow, family conference, very, very factual. As soon as you get into any sort of description, you run the risk of leaving objective world and going into subjective interpretation, which will not go over well with your reviewers. It's amazing, or with your readers. It's amazing how sensitive some people can be if you say something that they don't like. And so we've learned to become very, very objective with these. Remember, ultimately, no one should ever suffer or die as a result of process failures. This is why we're doing this. And by no one, we don't mean just the patients and their providers, but also the patients and their family members, but also the providers. So why do we spend so much time doing this, and why in the world are we still doing it this far on? And what is it that we're really trying to accomplish with this work? Change is difficult, but every single one of us who's done a mortality review or taken care of a patient in a hospital knows that not changing can be fatal. And what we're trying to do is be this little fish. I'm not a significant leader in the institution. I don't have a title in the place except for the mortality work. I have zero influence to make the system change. So we're just these tiny little fish trying to jump into the big pond to get our leaders to hear us. We're the eyes and the ears of the organization, and we want our leaders to change something. And that is an uphill jump sometimes. So you've been in meetings where there's data. Great, there's data. Everybody argues about how the data is, where it came from, is it severity controlled, et cetera, et cetera, et cetera. So those conversations, if you have data alone, don't usually go anywhere. We've also all been in those committee meetings where someone tells a very powerful story and someone else says it's just an anecdote because you don't have any data. So just stories alone don't work. We have to have data and stories, and the way that we've put the system together allows you to have both. And it is that both that creates the actionable information, and for me, the ability to stand up and inspire our hospital board to do something. Our organizational structure I reviewed last time, we've created both. So on the left-hand side of this, where the mortality structure and its particular activity, the reviews create the stories. Our M&M Council takes the data entered during the patient story data entry, does the analysis and the interpretation, and creates the data integration so that we can have the data and the stories to inspire change. That aggregate learning goes two different directions, clinical practice and quality. As I mentioned, we have no measurable influence in subspecialty areas or anywhere else. So we need to actually take what we learn to the clinical practice and to the quality, to the leadership, and tell them, this is what's happening. Here's the Pareto. Here's the statistical process control chart. I'm going to tell you some stories that go along with them that allow you to translate it into your clinical practice, and this is what we recommend. We do that in three ways. Case reports. We send out case reports after the end of each review session to the clinical leaders in each department. Why the clinical leaders, the department chairs? Because that's where they asked us to send them. When we first started doing them, we went to every clinical department and said, who do you want to get this letter? Every clinical chair said, I want them first. And then we allowed the grassroots response to occur. They send them on to their person, et cetera, et cetera. And every department has a slightly different way of handling these. We have quarterly reports. Now we get more into the data, where we aggregate information across the Department of Medicine, across the Department of Surgery, across the entire hospital, and we distribute it to every committee member, not just the committee chairs, committee member in quality and safety, and every nursing unit. On the nursing units, we attach to that for the nurse manager their report, all the data analysis, and a list of all the patients who died on their floor and a list of all the patients that had issues on their floor but died someplace else. And those have the committee summaries. Now remember, there's only committee summaries, that distillation of everyone's work on the cases where there were opportunities for improvement. So if there's no opportunities for improvement, then there's no case summary and it's just the patient's name. But the one they get of the list of issues that happened on their floor but the patient died someplace else, that all has the summaries on it because we reviewed all of those. And the third is a quarterly presentation. That brings the data and the stories together in person in front of our leaders. We go to our hospital practice committee meeting, which is the equivalent of our hospital board. Our chief quality officer sits in that room, and I can tell our hospital board chair and our chief quality officer the same data, stories, and interpretation at the same time, and we finish with recommendations. We've seen an increase in post-operative aspiration. This was a couple of years ago. And we recommend that a group of nurses be put together to look at this and specifically dive deep into it. Because remember, these are not root cause analyses. These are just our clinical interpretation of the patient's care. So someone needs to dive into them a little bit to get further into the root cause. And it's up to them, then, the leaders of the hospital and quality, to decide whether or not that fits on their priority list. I'm concerned it's really, really important, right, because that's the only thing I'm bringing forward. But a hospital chair and a quality chair have hundreds of things on their things to do, and only they can prioritize it. But it's our job to raise it, bring it forward, and package it up so that they have actionable information to do something with. Our morbidity mortality council, this is from a Six Sigma reliability perspective. This is some of the charts that we put out. I'm just going to go through these quickly because I discussed them before. We have statistical process control charts. We have heat maps. And this is our iceberg analysis, what I call it, which shows the lavender where the adverse event or harm. 45 patients had harm during those who died had harm during those 2 years, identified through our voluntary reporting system. 21 unique patients had issues identified with the electronic surveillance for hospital-acquired infections, and we had 263 patients with unique patients with harm identified through our mortality review process. Now we're beginning to find that same sort of yields when you look at readmissions in our high-cost cases, which are the ones that we're doing right now. Why does this structure work? I believe it because it moves away from insular peer review. We're promoting culture change by bringing people together and talking to each other. It's not unheard of now for somebody to walk in and say, yeah, we have our own mortality group now. We meet the Monday before this. We've talked about our cases, and then we've already decided to do X, Y, and Z. So this has grown on its own, and the concepts of talking about these cases to learn it's spreading without us having to push it, which is pretty exciting to watch. And again, it's not about the adverse events. It's not about attribution or preventability. It's about, is there something we can do better, and inspiring action through those stories. The last thing, the reason the structure works and the reason our chief quality officer loves it so much is that she can right-size our quality improvement initiatives. So if we can see it, because it's an enterprise solution, if you can see that something happening in every hospital, that's one size of an initiative. But if you can see that it's happening only on 1 or 2 floors in one hospital, that's a completely different sized initiative with different resources required. And so she's able to see through the system how big the problem is and how much resource it's going to take to fix it. So that brings us to the safety learning system collaborative that we put together. This is Dr. Paula Sandtrack's question to me. She said one day, when can we start learning from the living? Because we know that these things are happening to people who survive. So we're calling it our next generation safety learning system, and it's about organizational learning, identification of opportunities for improvement, and applications of the lessons we've learned to these challenging cohorts that we have not been able to get our arms around. And we have added a human factors taxonomy. I translated the DOD's human factors classification taxonomy used in the aeronautical space into healthcare. And it is embedded. So one of the questions I saw was, do the reviewers have training in reliability science or human factors? No, it's completely baked into the system, so they don't have to know anything about it, and I don't have to scare them by using engineering terms, which would keep them from actually finishing the reviews. So we've completely baked it into the new system so that they're actually doing that type of analysis without having to do the training, and allows them to do it as quickly as possible. The cases that Rochesters are working on right now are those listed here. Some of the other collaborative sites are doing some of these, and most are doing mortality-related work. We're introducing to the sites that are participating our tenets of the safety learning system, which are the multidisciplinary reviews, with nurses having an equal voice. I'm very serious about that. I believe that's the only place where, in our system, where a nurse can say something, a doctor can disagree, and we can have an honest conversation about whether or not it was an opportunity for improvement with no feelings being hurt. The practicing providers and deference to expertise, and the third tenet being those multidisciplinary case discussions, and the fourth is using this for actionable information and influence. These are the sites that are currently participating with us, and I'm in conversations with several others right now, going through various forms of their improvement processes to try to grow this collaborative. Many of these sites we're going to continue on beyond their 100 cases because the learning that they have had already has been so rich. So we're growing it, not starting a new one, so to speak, but we're going to continue to grow so that whoever joins now continues to learn from all the other people who have already been doing it. The goal is to identify opportunities for improvement with your first 100 case review. It can be at any cohort of your choice with the objective of learning within and across organizations. We'd like to get people to enroll during the fourth quarter of this year so we can go through local approval processes, IRB approvals if you want to participate with us in multi-center publications. And then quarter one, begin the 100 case review and finishing that within about 6 months so that we can do an analysis and further learning and publications as needed. This will be for your review later in the slide deck in terms of a basic timeline. As well, these are some of the training components that we go through. Again, this will be in your slide deck when you download it. The bottom line is, what does it cost? So for TMIT webinar participants, the cost is there, roughly $12,500. Those who come in who have not participated in this or the first webinar have a slightly higher cost. This cost covers all of the training, the materials, and data analysis, publications, etc. There's no cost for the software. I'm working with Mayo Clinic, and myself and another individual started a new social benefit corporation and nonprofit called HB Healthcare Safety. That particular entity is donating the use of the software and the enterprise solution for the collaborative participants. So for those who are not participating in the collaborative, in addition to the cost of the training and the materials and analysis and benchmarking and all of those other things, also pay for the software. So as collaborative participants, you would receive 2 personal on-site visits from me if you desire for the training, plus consulting time and as needed, plus 2 additional webinars for training and collaborative learning that I put on for any of the collaborative participants. You'll have all the materials for standardized case review training, project management support, study design, data aggregation and analysis, as well as benchmarking across participating sites. We'll coordinate the publications, manuscript, do site-specific report generation and benchmarking, configure the safety learning system for you and provide the IT support for that, and that use of that is available to you at no cost for the duration of that collaborative. And finally, just a couple screenshots of the system, the safety learning system IT solution, where there is the standardized reviews, workflow management capability that you can see on top, and then at the bottom, dynamic analyses and chart downloads, the Pareto diagrams, statistical process control charts, etc., are all annotatable, dynamic. You can click on one bar, it takes you down to the next lower level, etc. So,
Jeanne, thank you so much. I'm going to jump in real quick here so we can have time for questions. Kyle, make me the presenter, and I'm going to go to the polling questions. It'll help us a lot as we go forward on these topics. And so, Kyle, if you can make me presenter, I'm just going to move quickly to the and have you put up our polling, and then that way we have time for questions. This is just fantastic, and you can come back to the references and the resources. The first question is, I am interested in a webinar with speakers who have launched mortality review from scratch. So we want to know, do you want somebody who's been working with Jeanne, who's gotten started, just so that it can help you get started? And that would help us know if that would be helpful. So, Jeanne, we could invite some of your collaborators to speak. The second question, so go ahead, Kyle, and put the polling questions up. I want to make sure that they get up and that you all can see them and respond to the polling questions. The second question that we want to ask is, the polling review topics I want to learn more about are. So we'd like to have those. And Kyle, will you be getting the polling up? Maybe it's already up, and I'm looking at the Q&A. The topics
hey, Chuck, give me 5 minutes. They messed up.
Okay. So Kyle will get that up while we also have the Q&A. But we'd like you to tell us, you've seen a lot of great material by Dr. Huddleston, and if you could put those, give us free text topics that you may have seen and you'd like to know more about. The next question, and please fill this out if you can while you're listening to the answers to the Q&A questions and Dan Ford reacting. But the next question is, I'm interested in a deep dive on the MedTech causes of death of healthy people. These are programs that you could launch not only to your community, but also for your own, the people in your own organizations. And these would be people that are coming into your clinics and teaching the staff a number of these issues regarding Heimlich and where the AEDs are and CPR and a number of those, because we're seeing an awful lot of, in the larger centers, preventable deaths and preventable opportunities of the people you serve and also the people who serve. And the next question is, I'm interested in participating in a community of practice and helping develop those MedTech tools, such as the Care Huddle, which would be you put on a big educational meeting, and at the beginning of the meeting, you might take this small pocket flip chart and go through who will call 911, who will meet the first responders, who knows CPR, who knows where the AED is, so that if you want to be involved in that. And then the last two questions are, I'm interested in a webinar on all-cause harm to those we serve, the patients, that would include Jeanne's work, and also those who serve, our caregivers, so that we look at an all-cause harm, omission and commission, broad picture. We'd like to know if you are interested in that. And then the last question is regarding the emergency. The second last question is on emergency code harmonization. Are you interested in a collaborative that could help you across your organization revitalize? Do we go to clear message, simple text, get away from colors, and get some standardization regarding emergency codes, and we'll cover that in the future. And finally, the question is, what's keeping you up at night that we may not have covered that you'd like to see? So Kyle will get those questions up, but I'd like to turn to Dan, and we'll go over a few minutes. Dan, would you like to react to what you heard representing patients and families, and then we open it up for questions?
Okay, yes, I will. One of the early comments that came across that the faculty had some access to was the fact that somebody commented this was a game changer. And from the patient family perspective and from everybody's perspective, I would hope that it is, and it seems to be. Secondly, and I'm going to plant more seeds and ask questions, is I'm curious about how much support there is by the medical staff, and I hope you're making enough doctors nervous that they get curious and you can turn their heads in a positive direction. Thirdly, curious about patient and family involvement in the form of PFAC kinds of representatives who can be constructive and who want to be part of the change, that are included on the, at least on the committee work and maybe in the independent reviews. I think that could be constructive. And lastly, on this piece of it, Chuck, is it seems like process improvement is a very key part of this. I don't know how much of this is process improvement, but I'm guessing a lot is, and that it really shows the value of the process improvement piece of this. That's it.
So Jeanne, maybe start with the last, involving patients and or process improvement. But Dan is such a champion of involving patients and families. Has this information been shared with patients and families, and also the question regarding the receptivity of the medical staff?
So I have taken this to a PFAC, or a Patient Family Advisory Council, that I chaired, and shared the results with the patients and with a community group as well, to get their input on what their experiences have been and what their suggestions might do. We have not yet involved anybody in the committee discussion. It's something I'd love to see happen. We're just a little slow on moving that directly into our care areas. There's no doubt this is QI, process improvement activities. But it's sort of the preemptive part. We're teeing up what needs to be done, creating the actionable information so the process improvement can actually happen in a meaningful, direct way.
The question, while we're waiting for the polling to come up, and we're sorry about the delay there, would you, Jeanne, do you think there are some collaborators that you have where you've been able to transplant this from Mayo to other organizations that would be willing to speak to our audiences that are maybe, worried about, well, how do I get this started, and how did you do it? Was it easy or hard, or what were the surprises, et cetera? Do you think there might be some collaborators that might want to speak?
There absolutely would be, especially as we get towards the end of the year and the end of our the first 100 cases that the first group is going through. Then there'll be a number that have experience, and we're planning on publishing as well.
What about the start from scratch question? Just getting an organization. And maybe you can answer that question in case we don't get the polling up. Would you tell us about how can an organization successfully kind of bring this in? I see the polling questions are up, so we would really appreciate you all responding to the questions quickly so that we can guide the future webinars. But maybe this one on the start from scratch question, what advice is for those that are listening and think, gosh, this sounds pretty good, but where do I start, and what am I hooked to get my organization in the game?
That's probably different from hospital to hospital based on its organizational structure and politics and where the person sits in that realm. We started just by literally reviewing 100 cases and finding stuff that we thought was meaningful and powerful and sharing it with our leadership. So it was nothing fancy. They were yellow pads of paper. And so that would be one way. The other way, obviously, would be to join the collaborative, and we'll walk the journey with you.
So if a group were to join the collaborative, you'll help them communicate the value proposition to their organizations. Is that a fair statement?
Absolutely. Great.
That's very helpful. We're going to go over just a couple of minutes, and would like to and now that you've reviewed things, Jeanne, I want to throw it back to you on what we've covered and what we've discussed. Are there additional things you'd like to say? And I'm watching the Q&A window, and I know people have to drop off to go to their next commitment, but do you have other things that you might want to add?
I frankly do not. I want to be respectful of everybody's time, and I'm just so grateful for people being willing to participate and for your invitation, Dr. Denham.
So one quick question was, what proportion of the mortality reviews conducted were about omission to rescue hypoglycemia?
I remember 2 out of the thousands that we've done, but keep in mind they're only deaths. I know that it's happening on a much larger level, but I only remember 2.
And you have rapid response teams at all the Mayo sites? Yes. And would you recommend rapid response teams for those that haven't employed that? There was some debate on the data regarding rapid response teams.
Oh, absolutely. There's no doubt that it's helped contribute to our reduced mortality rate. I mean, if you treat patients sooner, they do better. I see there was another one here about keeping the committee or groups or keeping names of people out. We just don't transfer the names of the providers into the mortality review system, so that when we're doing the discussions, there's no names there. And names have never accompany the case reports that go out or any of the reports. People can go figure it out, But the gist is just to have a good, solid conversation about the issues, not the people.
Great. Well, we want to be respectful to everybody's time. Again, sorry about the polling getting up a little late. We'd like the speakers to stay on so we can do a performance improvement loop and visit with Eugene about next steps, and perhaps inviting some of the collaborators, to participate in helping educate us. But we'd like to turn back to Dan and the voice of the patient. Dan, thank you for your reaction. And also, would you please close us? And God bless you all. And we hope you have a great end of August and summer. And we'll look forward to seeing you in September. Dan?
I will. Jeanne, thank you very much for what you've contributed today, for your passion, for your energy, for your courage and your willingness to blaze these new trails, for your focus on the patient as well as clinician improvement. And I truly do hope you're making enough doctors nervous that they want to turn around, they get curious, and that they will participate in this change process. And the audience, thank you very much. I hope you will keep your seatbelts on, keep them buckled up as you take whatever you've learned today forward, and perhaps even make contact with Jeanne and the invitation that she has thrown out there to you. Thank you very much.
Great. Thank you. And that closes our webinar. Speakers, please stay on.